Are visible. Thank you very much, madam, for this wonderful opportunity. Thank you, ARC, and especially Dr. Chitra, madam, our dynamic chairman, who's been doing a very good job. So I'll be speaking on the staged manner, stage management for the FTMH with cataract, and I think very relevant points has been put up by Dr. Jatinder sir. But we all know that the success of the FTMH surgery has been reported with a failure of 10%. But nevertheless, it doesn't matter. The treatment for eyes with cataract as well as it's definitely a point of debate. See here, if you see in the recent past, the most surgeons opt for a combined surgery, that is combining phacoemulsification, IOL implantation, vitrectomy, ILM peeling, and tamponade. Agreed. Contrary to that, to quote a few of the many studies. So let's look into this. A comparative study by Muselier et al. Carried in the year 2010 concluded with a similar and the positive anatomical and functional outcomes after both combined as well as sequential surgery. Let's look into this another interesting article by Wang C et al. In 2019, which says that the medical cons of the combined surgery include poor visibility, increased inflammation, cystoid macular edema, IOP spike post-op, IOL displacement, and non-medical, definitely the referral relationships are hampered. Jatinder sir is in a very good kind of setup with the eye foundation where you have a lot. But if you are a standalone retinal surgeon and the case has been referred to, you know that there is a cataract. If we don't ask their permission and touch the cataract, I think that's the end of referral relationship between the retinal and the cataract surgeon. So it's a worth to read at this paper. That's a closer look at combined cataract and vitreoretinal surgery. Is it together better? Another study by Shido showed increased cystoid macular edema in combined surgery for cataract and full thickness macular hole. Another study, Tranos et al. Was suggestive of better refractory outcome in eyes undergoing sequential cataract. We all know that after doing vitrectomy, it goes into myopic shift. So sir suggested that we have to take 0.5 mm less, but it is still a guess. We are not very sure about it. That's why this paper has come out very nicely, recently published in Graves in 2020. I think it's worth reading why combined is not better for refractive surgical outcomes. So let's look into some of these complications. I'm not telling that in every surgery it happens, but definitely, even if it happens in 10 out of 100 cases, yes, definitely that is a large number, which definitely I would like to consider. Everything was going well, did a nice rexus, the phacoemulsification was done, a direct chop technique was done, IA was being done, but you see at the end here, there was a meiosis. Definitely, you can use the epitrate, you can use all sort, visco, pisco, and everything. You can try to dilate, see the amount of sometimes the wound burn, although you can definitely clear the view, but why go into such mess? Now, let's look into this another thing. Of course, it's a rare, now the ability of the cataract and the vitreoretinal surgeons have definitely improved a lot, but definitely there are certain chances of the PC rent. So, right, so everything was going well and the PC rent occurred, and since being handled by the vitreoretinal surgeon, it was taken up from the pars plana route. And in the event, the patient developed a little bit of epithelial edema, so the epithelial scraping had to be done in this case. And although the surgery went well, you can see the clarity of the view, but definitely initially it was a little bit of mess here. Now look at this staged kind of procedures where the phaco and the IOL was done a week before. And this was the case where the primary ILM peeling was done, but the MAC hole failed. Now look at this intra-OCT, so beautiful. Now I'm putting a viscoat inside this macular hole and I'm trying to do an ILM transplant. I'm trying to take the ILM from the periphery and try to stuff it inside. But since it was a pretty large hole, I needed a little bit more ILM from the periphery. So getting a good sheet of ILM is very, very important. So peripheral visualization definitely comes to play in this. And again, after stuffing it, you can see the flaps being placed inside the MAC hole. And the patient, you can see here, improved from 660 to 618 with the type 1 closure. So let's look into this another kind of holes where the primary MAC hole surgery was done. And you can see the hole size. It was nearly 1000 micron. So, right. So in these cases, I just cauterized and did a bleb induction. And then I did a bimanual surgery in this. And took that piece of the retina and just stuffed it over the MAC hole. And then PFO was injected and a nice graft placement. Now look at this IOCT. So beautifully you can see the nice placement of this graft over the failed MAC hole, and finally the macular hole closed very well with 3 to 4 lines of Snellen improvement in this case. So non-medical issues, as I told you, the referral relationships sometimes might get hampered if the VR surgeon opts to operate cataract as well. And sequential surgery, preoperative, as I had said earlier, we need to look at
remaining.
Yeah, more correct IOL power and the refractive outcome. And definitely intraoperative, less surgical time, less ocular handling, need to leave the patient aphakic in case if it's an eventful surgery, if it's a large rent. And definitely, if you like to if I want to summarize, pros are there. I agree with Dr. Jatinder sir. Economically better for the patient, need for multiple procedures are avoided. Risks involved after intraocular surgery is avoided because both are done in single sitting. Similar functional and anatomical outcome in between both staged as well as the single early recovery. But let's look into the cons here. If it's a dense cataract, cornea becomes hazy, and then during phacoemulsification, it becomes difficult. During vitrectomy, it becomes difficult because of the wound burns and a little bit of the hydration of the cornea. Refractive errors, I have already told, myopic shift happens due to pars plana vitrectomy. Pupillary constriction might happen intra-op. Trocar placement, sometimes if you're using the trocar or blunt trocar, when you don't have a sharp trocar, definitely the wound collapses unless we have a visco in the anterior chamber left. And again, after the surgery, you have to remove the visco by the AC wash. Again, IOL displacement, optic capture because of the tamponading agent. And sometimes if there is a slightly zonular dehiscence elsewhere and if you are putting a gas, the C3F8 gas coming into the AC and staying in for 4 weeks is a horrible, horrible situation. Increased incidence of inflammation and CME. It's not just said by me, the papers have proved that, and definitely there is increased chance of post-op IOP spike. I want once again thank Chitra madam for this opportunity. Thank you, Jatinder sir.
Thanks a lot, Srinivas. I do see Dr. Purendra Bhasin now, so I will just take one question because you're really running short of time. Dr. Purendra Bhasin, in this kind of a case, I didn't see you at all, so I couldn't include you. In this kind of a situation, with the vitreous tamponade and all being done, would you consider that the cases should have a smaller axis, or would you think of adding a pilo later so that there is no optic pupillary capture occurring in these cases?
I would have definitely loved to use the pilocarpine in such cases at the end of the surgery, because then there is a little chance of vitreous to come forward. So I agree with you.
And another thing, Srinivas, would you all think of using pupil expanders when you're doing vitrectomy? It's not done?
Yeah, we use it, madam. But now with the wide angle system, even with the 4 mm pupil, we can still do a fantastic posterior pole surgeries. But definitely when you are doing a base shaving or the peripheral vitrectomy, definitely I think the better the area, then I think better is for the peripheral surgeries.
Okay, we shall, sorry, I'm not giving more discussions. We are running very